Good morning to everyone. My name is Mrs. Malliga N, BSc Nursing. I am working as a nursing tutor at E.S College of Nursing, Villupuram. Today my topic is hypothyroidism. First, definitions of hypothyroidism. Hypothyroid state resulting from secretion of thyroid hormone and characterized by a decreased rate of body metabolism where T4 is low and the TSH is elevated. Next, causes of hypothyroidism. Then primary is the thyroid failure. The secondary, pituitary thyroid stimulating hormone deficit, that is hypopituitarism due to pituitary adenoma, apoplexy, infiltrative disease, sarcoidosis. Next, hereditary hypothalamic deficiency of TRH, peripheral resistance to the action of thyroid hormone. Major causes of hypothyroidism. The primary hypothyroidism, chronic autoimmune thyroiditis, Latrogenic thyroidectomy, the radioiodine therapy or external irradiations, iodine deficiency or excess, drugs, thionamides, lithium, amiodrone, then interleukin 2, infiltrative disease, then fibrous thyroiditis, then hemochromatosis, then saroidosis. Next causes, transient hypothyroidism, subacute lymphocytic thyroiditis, subacute granulomatous thyroiditis, then postpartum thyroiditis, subtotal thyroidectomy, then following radiation therapy for grievous hypothyroidism, the following withdrawal of suppressive doses of thyroid hormone in euthyroid synthesis. Next, central hypothyroidism, TSH deficiency, generalized thyroid hormone resistance. Next, types of hypothyroidism. Then primary hypothyroidism such as iodine deficiency, autoimmune thyroiditis, the previous thyroidectomy, previous radioiodine treatment, the previous external beam radiotherapy to the neck, drug like amiodrone, the lithium. The central hypothyroidism, the lesion compressing to the pituitary such as pituitary adenoma, then cranioparenchyma, next meningioma. First, iodine deficiency hypothyroidism. When iodine deficiency is a more severe, thyroid hormone production falls and the patient may experience a hypothyroid condition. In such cases, adults have the usual signs and symptoms of hypothyroidism and may lead to myxedema. In congenital, in fetus and young children, previous CNS development and maturation resulting in permanent mental retardations, neurological defect and growth abnormalities. Drug-induced hypothyroidism, drugs such as thionamides, then propylethiouracil, next methimazole and carbamazole inhibit the oxidation of iodide and the subsequent binding of iodine of tyrosine residues. Lithium, which is used in treatment of bipolar disorders, can induce hypothyroidism. Action of lithium appears similar to that high doses iodine, inhibiting thyroid hormone release and organification of iodine. Prolonged use of nitroprusside may lead to hypothyroidism. Drug-induced hypothyroidism, cyanide release from nitroprussides in metabolically converted to the thiocyanines which inhibit iodide uptake by the thyroid gland. Then amiodrone is an antiarrhythmic drug that contains 2 iodine atoms per molecules and can induce hypothyroidism or hyperthyroidism. The various recommend DNA-derived biological substance used to treat chronic viral hepatitis in cancer have been found to cause thyroid dysfunction like interferon alpha, interleukin 2. Surgical and radiation-induced hypothyroidism. Although the hypothyroidism develops after surgery or iodine therapy or grievous disease is usually permanent, it may be temporary, especially in the first 3 to 4 months. In symptomatic at these early stages, patients should be treated with relatively small doses of thyroxine. Therapy will be required lifelong. If serum TSH remains elevated, thyroxine therapy will be required lifelong. If at this stages serum TSH is normal or undetectable, stopping the thyroxine for 4 weeks and retesting thyroid function would be in the appropriate actions. Hashimoto-thyroiditis is characterized by the destruction of thyroid cells by various cells and antibody-mediated immune process. The females are affected with a greater frequency than males. The gland is especially enlarged but small and fine in early cases with a palpable pyramidal lobe. At this stage, hypothyroidism may transiently occur, but further gland damage rapidly leads to permanent hypothyroidism, at which stage goiter, regress, and the gland remittent is recommended for fibrous tissue. In patients with the metabolism have antibodies to various thyroid antigens, antithyroid paradox, antithyroglobulin, TSH receptor blocking antibodies. In about half of patients with the metabolism, serum TSH is elevated and T4 normal, the subclinical hypothyroidism. The other patients having overthyroid failure. Then viral or bacterial thyroiditis occurs very rarely. Recurrent thyroiditis is an unusual condition which often follows a viral illness. Readult thyroiditis is extensive replacement of the thyroid with the fibrous tissue causes the glands to become story hard. Then viral infection or subacute thyroiditis can produce generalized thyroid gland tenderness. The bacterial infection or acute thyroiditis and can produce a thyroid abscess. Central hypothyroidism, insufficient stimulation of the thyroid gland by TSH. Secretion of TSH can be impaired at the hypothalamic or pituitary levels. Causes includes tumors, hemorrhage, trauma, malformation, post-infectious damage and post-surgical damage. Congenital hypothyroidism. The congenital hypothyroidism is an inadequate thyroid hormone production in newborn infant. This can occur due to an anatomic defect in the gland, inborn error of thyroid metabolism, then iodine deficiency and ineffective transport, inability to organify trapped thyroidal iodide. Secondary hypothyroidism, loss of TSH derived through thyroid function may result from any of the causes of pituitary glands hypofunction. Recognition of etiology of the type of hypothyroidism is critical and is usually made by observing a low T4 accompanied by a inappropriately normal TSH concentration. In some cases of secondary hypothyroidism, TSH may be slightly increased. Increased T3 and T4 ratio are not seen in the type of hypothyroidism as TSH drive is absent. Myxedema, coma, then symptom like the hypotension, hypothermia, then hypoglycemia. Next, clinical manifestation of cold intolerance, weight gain, bradycardia, constipation, menstrual disturbance, dry and coarse skin, thin and brittle nails and hair. Lethargy and fatigue, weakness, muscles pain, then paresthesia, generalized puffiness and edema around the eyes and face, myxedema. Forgetfulness and loss of memory, menstrual disturbance, goiter may not be present, cardiac enlargement, tendency to develop heart failures. Treatment, admit ICU for continuous monitoring of CVS and pulmonary status, supportive care, ABC measures, then treat hypothermia with passive rewarming, then treat hyponatremia with NS and free water restrictions. Thyroid hormone treatment, levothyroxine T4 loading dose 300 to 400 microgram IV, 5 to 100 microgram IV daily. The until oral medication can be given. In suboptimal response, consider concurrent lithothyroidine T3 5 microgram is every 9 hours. Then corticosteroid therapy, first draw baseline cortisol level and start hydrocortisone 100 mg IV and followed by 50 mg IV every 6 to 8 hours. Follow steroid therapy. The nursing intervention, monitor vital signs including heart rate and rhythm. Administer thyroid replacement is most commonly prescribed. Instruct the client about thyroid replacement therapy and about the both hypothyroidism and hyperthyroidism related to under replacement of or over replacement of the hormone. Instruct the patient in low calories, low cholesterol, low saturated fat diet and discuss a daily exercise program such as walking. Assess a patient for constipation, provide roughage and fluids to prevent constipation. Provide a warm environment for the patients. Avoid sedatives and opioid analgesic because the increased sensitivity to the medication may precipitate myxedema, coma. Monitor the patient to report episodes of chest pain or other symptom of overdose immediately. Thank you.